So this patient's coming in for an expanding cyst that's been growing over the course of the last couple of weeks for her. I'm working with Dr. John again today. So what do we think this is most likely? What type of cyst?
A back cyst.
Close enough. So an epidermal cyst, very good. And you can tell, so see how the pressure's there? So it's trying to evacuate itself, all those puncta that are there.
I see.
So it's trying to drain itself. So we just want to put some antiseptic in. So this means that there's an inflammatory process going on. Whether it's infectious or not, that's the stuff that's come under debate. We used to always think that this meant there was infection, but lots of studies show that it's not. It's just inflamed.
I thought that a cyst was always infectious.
Yeah, no, it's not.
Or an abscess at least. Yeah.
So an abscess is different. So this is a cyst that's gotten inflamed.
Okay.
So, but having said that, the inflammation creates a pH balance that's different, and anesthetic functions on a pH balance. So how well this will work will be impaired. So you want to make sure that we inject this superficially. So you're going to feel a little poke here. I apologize. So we want to be very superficial with this. So we want to see this blanch, just like that. I apologize.
Oh,
Is there epi in that one?
There's a little bit of this, yes.
you got it, John.
Yeah, you're doing well. Because if we inject right into the capsule, even though sometimes you do that a little bit, if you distend this capsule, it's really uncomfortable for her. So first and foremost, you want to inject the surface. So you want all of that to be blanching. See how that's pushing back against it, leaking a bit. So I want to have as good a freezing here as possible, because just like we were talking about that laceration,
Yep.
the main nerves are right at the surface, right at the skin.
Right.
She'll have some deeper, but those ones feel more like nausea as opposed to really, really sharp pain. So we want to make sure that these at least are well frozen. And then I try to inject a little bit deeper. I apologize for this because this will probably be into the capsule. See how she's oozing throughout it?
Is the capsule then the major difference between the abscess and the infected cyst?
Yeah, completely different. So an abscess has no capsule and a cyst does. Does that hurt when I do that?
No.
All right, so now we're going to take our number 11 blade. So that's this one that's just very pointed. And we're going to be incising into this. Just breathe best you can. Now, if we had to swab, is it a good idea to swab this right now? What is pus?
Dead white blood cells.
Exactly. So should we swab that? What's it going to grow? What is dead white cells going to grow?
Skin flora?
It's going to grow nothing because it's dead.
Okay.
So my point being is this is a mistake that we often make. Sorry, honey. So the issue there being is generally I'll go over with you swab technique. We'll show you a couple of videos.
Okay.
So see how that's more firm there?
Yeah.
So that's keratin, it's just breaking down. So this is the difference where as soon as you see that, you know it's not an abscess. Like this is an actual cyst that's gotten infected.
So that's
inflamed.
Okay.
That's the keratin, the firm material. Now when it's gotten like this, unfortunately, we can't take the membrane out because it becomes extremely friable. It's like very frustrating. You just can't get it out.
From inflammation.
Yeah. Does that hurt, honey?
Mm-mm.
Not too bad. So I'm using the pickups like a curette. I'm just trying to break down adhesions. Now how well I can do this will depend on how good her freezing is. So oftentimes when it's an inflamed field like this, it's not good enough. But when I do that, see more comes out.
Mm-hmm.
Because you break it down and you'll get more out. So you notice that lovely aroma.
I don't even smell anything.
So that's just because it's gotten inflamed, probably infected a bit in this case. But see how that's coming out in pieces?
Mhm.
That's because I'm breaking down some of the adhesions and then more of that's coming out. See this here? That's membrane. See that there?
That's from the capsule.
Yeah, but that's what that looks like. This is why you can't get it out entirely, it just breaks apart. But this is why you should have lots of 4x4s, because some of these can really drain a tremendous amount.
Does that feel better?
She'll have less pressure once we're done with this.
Right.
And you want to try and get as much of this out as possible. So that this has a chance to heal. Because you do want to clean these out, because this is the big difference between in the past, we used to pack these for weeks. The newer studies are showing we may do that for abscesses, but for infected cysts we don't, because It just is uncomfortable for the patient. It doesn't encourage healing. As long as when you first do it, you clean it out pretty well.
Right.
Because if you're just doing it, so if people make a very small laceration, they don't try to break down adhesions, they don't put pressure on it, they don't actually try to syringe it out, then you're going to have so much retained material there that when it does seal, it's going to get re-inflamed very quickly. So once I've gotten most of that out, do you want to grab me some more 4x4s?
Doing good, John.
You're doing really well. You're okay?
Where are they?
Right in that jar in front of you on the table.
Oh, just those.
Yeah, just grab a bunch of them. So I'm just going to get you to hold a couple around here because we're going to syringe this now. So essentially, I want to syringe this at different angles because I'm just trying to, again, clean this out. And even just the syringing will break down a certain amount of adhesions. So you'll see once I've done that, see you got some out right there?
Mm-hmm.
The actual syringing breaks down the wall as well, and you get more cyst material out, which is what we want. You okay?
Mm-hmm.
So I'm just going to irrigate it one more time. Pretty clean. So see, it gets more serosanguinous.
Will the cyst necessarily reform?
Yes, that's what I'm saying to you. This is not, you can't remove it properly. We'll have to be looking at this down the road to take it out completely.
But where the capsule has been broken up, it 100% of the time does reform?
In ones, the only time it doesn't, where you can get lucky, is if it's a very, very small cyst. So sometimes fascia ones, which are more like pilosebaceous units like milia, you can just unroof them, and then that's usually enough damage that it doesn't come back. But anything substantial, like unless you're taking out, I don't even know what a percentage would say, but I would say at least 85% of it is coming back.
Okay.
So sometimes you get lucky. So if it just got inflamed and you're getting big patches of the actual cyst membrane, you can kind of grab it and get it out, you'll get lucky. But I would tell you the majority of the time, once it becomes really inflamed, especially a case like that where you're seeing the puncture beforehand where it's trying to get out,
Yeah.
it just won't clear unless we actually drain it, allow it to heal, and then we'll have to go back in when it's not inflamed and we take the entire cyst out.
Okay.
You okay?
Mm-hmm.
See, right now we have freezing in, so she's tolerating this, even though I guarantee you this is still a bit uncomfortable for her. But like tomorrow, if I was to do this when I don't have freezing in, it's really uncomfortable. And because it doesn't actually help it heal quicker, we just don't do that anymore.
Okay.
But you'll still find people who don't do cysts regularly, who will have patients coming back because they're treating it like abscesses. They'll pack them for weeks.
Yeah.
So this stuff, I cut it by the front spot first, and then I just go closer. Very good. Oh, you know what I forgot to do, which I'll do now? I meant to tell you this too. So for swabs, I want to take the swab after it's cleaned out as much as possible. So after I irrigate, this won't matter here. I'm just going to be doing it beside it. So I'm going to stick this in. Because this is why we do it now, because what I'm looking for is live bacteria. So essentially you want to clean it out as much as possible, which almost seems counterintuitive, but you want to be getting live bacteria that has a chance to grow, and then we can actually see what it's sensitive to. So I'll send that off to the lab. All right, so we'll see here back tomorrow and then see how we do with things.